Welcome this afternoon, everybody. I'm Jen Kovich-Bordenick, the CEO of the eHealth Initiative and Foundation, and we're really delighted that you're able to join us here today. We've got a wonderful program for you this afternoon. We're going to be talking about telepsychiatry, best practices, and regulatory priorities. This is all part of our COVID-19 webinar series, which we launched about, 2 months ago. It's been that long here. And we've got a really, really incredible group here for you today. We've got Jeffrey Boyce, who is the CEO of Insight and Regroup. We have Irene Epstein. Dr. Epstein is an adult psychiatrist with the Whiteside County Community Health Clinic. And we've got Naveen Kathuria, who is the Senior Vice President of Growth and Advisory Services of Insight and Regroup, and a really, really incredible program we're going to get to today. But before we do that, we've got a couple of quick housekeeping items that we're going to go through for you. Everybody is on mute. I saw a couple of chat questions about that. Everybody cannot, we can't hear you speak right now, but we do want to hear from you. So if you have questions, please go ahead and put them in that Q&A box in the bottom of your screen, bottom middle. It says Q&A. Go ahead and type in there your questions, and we will get to as many questions as we can at the end of the day. I know several of you submitted questions beforehand, and we have several of those on hand as well. But let us know what you're thinking about, what your concerns are, and if you have a specific question for Irene or Naveen or Jeffrey, let us know who to direct it to as well. If you're having issues with hearing or technical difficulties, go ahead and click on that chat bar right there, and that would be great. We will try to link you to whatever we need to link you to. Those of you who are looking for copies of the slides, there is a link right there, ehighDC.org/resources, which you can get a copy of the slides. We will also be sending out tomorrow a copy of the recording or the presentation that's going to happen today, along with a copy of the slides and any resources or other items or documents that come up during the call today as well, so that you have everything in one place. Next slide. For those of you who are not familiar with the eHealth Initiative and the Foundation, our mission is to convene executives who are transforming healthcare through technology and innovation. And programs like this, education, research, and advocacy, this is really what we do around key topics in healthcare and technology. Next slide. Next slide. Thanks, Claudia. And we've got an incredible group of leaders and organizations that we work with on a regular basis. This is just a sampling of some of the groups that are involved in our leadership right now. And we would love to have you involved. If you're interested in getting involved, go ahead and send us a note through the chat box right there, and we'll get in touch with you afterwards. We are looking for payers, providers, labs, psychiatry, behavioral health, vendors, researchers, academia, all different sorts of folks, anybody who's involved in healthcare and technology, and we're trying to connect all the different pieces together because we recognize we have quite a disparate system, and it isn't about one group or one stakeholder group, but it's really about all the pieces fitting together. Next slide, Claudia. Generally, these are the areas that we focus on, our educational programs: transparency, interoperability, privacy, and analytics. And you can see there's a whole assortment of topics under there that we generally focus on. Next slide, Claudia. But we've been really focused over the last 2 months on COVID-19 and how all of these different issues, transparency and privacy and interoperability and telehealth, how all of those things are impacting COVID-19. And this is a sampling of some of the upcoming programs we have in the next few weeks. We'll be talking to Lisa Ide at Hypnosis next week about telehealth. We've got a great program coming up on the 21st with Len Lichtenfeld, who's the medical director at the American Cancer Society, talking about cancer patients and how they are currently dealing with care that's been postponed and trying to get care in this environment right now, and how they're handling that as well. And a whole slew of other programs coming up. That's just a sampling of them. If you're interested in a program, please go ahead and reach out to us or reach out to Amy. And before we turn it over, I do want to just thank, again, Insight and Regroup. EHI is a really small nonprofit, and putting on all these programs and focusing on these things is really the result of organizations like Insight and Regroup who support our efforts and recognize the importance of these things that we're talking about here today. So I do want to thank them. And we're really fortunate to have such expertise with us on the line today. Next slide. So I'm actually going to turn it over to Jeffrey now and let him tell you a little bit about himself, and then we'll get started with the program. Jeffrey.
Well, thank you so much, Jen, and thank you to everybody at the eHealth Initiative for the opportunity to be here today. We're really glad to support the organization and your mission, and really glad to have an opportunity to share some of our learnings from our work within the field of telebehavioral health. So I'm Jeffrey Boyce. I'm the Chief Executive Officer of the organization. I've been doing this for about 11 years now, and I have learned a lot of lessons along the way. Many of those are things not to do. I'm happy to share those and some of the things that you should do in the area of telebehavioral health with you today. Also really pleased to be joined by two of my distinguished colleagues who I'm going to give a chance to introduce themselves. Irene?
Hi, everyone. My name is Irene Epstein, and I'm really pleased to be here today. I am the Associate Medical Director for Scheduled Services at Insight Plus Regroup, and I am also a practicing telepsychiatrist. I see patients at Whiteside County Clinic, which is an SQHC in rural Illinois, and I also see patients at a prison that is part of the Illinois Department of Corrections.
Hey everyone, this is Naveen Kathuria, also very pleased to be here. I'm a Senior Vice President of Partnerships and Advisory Services here at Insight Regroup. I've been an attorney since 2006, focused on healthcare. But my role here is really to find ways to navigate the ever-changing regulatory landscape to be able to deliver the solution that we offer, which is telebehavioral health services. So excited to share more with you and hear some of your questions.
Well, great. I think with that, we can move on to the next slide. And we're going to dig in and go through some content relatively quickly. I think we really want to save a significant amount of time in today's conversation for a back and forth and a lot of questions and answer. But did want to start with a very brief introduction of who we are and the perspective that we're bringing into today's conversation. We're a leading telepsychiatry service provider in the US, and we're founded with a mission to really transform access to high quality behavioral health services. We serve several hundred organizations and thousands of individuals in various settings across the continuum on a regular basis. And we do that through three different operational models: on-demand scheduled services, and our home-based service offering called Empathy. We're going to tell you a little bit more about how each one of those models work and how those delivery mechanisms might apply to you. We started doing telepsychiatry way back in 1999. Since then, we've probably done over 2 million telepsychiatry encounters. We weren't counting very carefully in the early stages, but we've done a lot of this, and our focus is absolutely on delivering clinical services. But in our free time, we try to be an active participant and thought leader within the industry, and really try to help have a voice in shaping the regulatory environment around us. So we're going to dive in. Before I do, I just want to calibrate quickly on terminology. You'll hear us use the words telepsychiatry. You'll hear us say telebehavioral health. We'll probably use these two things interchangeably with one another. But when we do this, when we say either one of these words, I want to clarify that we're primarily talking about the delivery of psychiatry or therapy or counseling in real time via live video. We're not talking much about the delivery of services over telephone, and we're also not extending that definition to include other newer asynchronous technologies like chat and AI and virtual reality and things like that. So primarily we're talking about video conferencing based behavioral health. So with that caveat introduction in mind, let's dive in. I think we can move on to the next slide. And really, I think I can be really brief here. What we wanted to illustrate is some of the settings where telepsychiatry is currently being used. And the bottom line is basically that it's everywhere. So any practice environment that you can think of has some form of telebehavioral health happening within it. I think the really interesting thing that's happening right now amid COVID is that we're not thinking about these environments separately. Telehealth is really playing a critical role in bridging between them, and we're extending behavioral health resources in new ways really all across this continuum. I think that is particularly true in ambulatory settings where clinics are converting to home-based models, and I know we're going to dig in there more. So with that, I'll turn it over to Irene. Irene, are you there? You may be on mute.
Yeah, I apologize. Thank you, Jeffrey.
There we go.
No problem.
Next slide, please. I knew that was going to happen. Okay. So in the following few slides, I just really want to highlight the mental health care gap that exists pre-COVID in emergency room, hospital, and ambulatory settings. So let's first take emergency rooms and hospitals. Many of the patients that are coming into the ER are there for mental health reasons. So in fact, 1 in 8 ER visits requires a mental health consult. These patients are waiting a long time to see a clinician and receive care. So you see 90% of psychiatric patients end up being boarded in the emergency room, and 40% actually have to wait 2 days to see a psychiatrist. This is much longer than the average patient in the ER, and it's clearly very costly. Now with COVID, the need to treat these patients and determine the disposition for them in a timely manner is particularly urgent because we know that ERs are packed right now, and there's just also the increased risk of transmission the longer patients are in these enclosed areas. Next slide, please. The situation is similar in the outpatient setting. So 1 in 5 Americans receive mental health care services in a given year. So clearly the need is high, but there's a significant shortage of psychiatrists and other mental health clinicians. And this is for a variety of reasons, including the nationwide shortage and uneven distribution of clinicians in big cities and coastlines, leaving great swaths of the country with little care. Of course, there are also funding issues. Additionally, the psychiatrist pool is aging, and we expect the shortage of psychiatrists and other clinicians to intensify in several years. This results in 60% of adults with mental illness not receiving care. Next slide, please. So into this grim scene arrives COVID, which of course not only exposes the cracks in our system, but also widens them. Most experts agree that emotional disturbances are expected to rise both acutely and over time due to COVID. And you see here there are multiple stressors that are contributing to our collective anxiety. There's of course the fear of contracting the illness, the fear of loved ones becoming infected. There are also financial concerns, inadequate information, the self-isolation measures that are associated, we know with feelings of depression, anxiety, hopelessness at times. And I think a really essential element of our collective anxiety is just a sense of uncertainty about how long this will last, what the economic impacts will be, and what the world will look like. So this pandemic will no doubt result in escalating mental health needs and an exacerbation of mental illness in those who are already in our care. But now we're not just running up against some of the issues that I alluded to before, but new ones as well. So right now, many healthcare facilities are shutting down temporarily or decreasing services to protect patients and staff. Also, patients are unable to come in or reluctant to come in due to fear of getting ill or new travel restrictions. Next slide, please. Recent polls actually support our sort of intuitive sense that mental health disturbances may rise with COVID. So there's been a recent poll, and over half of the participants noted that COVID has been associated with negative effects on their mental health, including an increase in substance use. There's also been a real uptick in prescribing of antidepressants, anti-anxiety medications. And interestingly, over 70% of individuals say that they would be much more likely to actually seek care if they could access it through telemental health services. And I believe that telemental health is uniquely poised to be able to respond to some of the mental health needs of people that are in isolation or have restricted mobility. It would also, of course, help us adhere to the social distancing rules and not only avoid care interruptions, but also meet the growing mental health needs. Now I will turn it back to Jeffrey to talk about some of telemental health solutions.
Yeah, thank you, Irene. I think if we look over on the next slide, you framed this up really well. But the short story here is that the impact of COVID-19 in this crisis is going to have a significant and a long-term impact on the mental health of our nation. We're seeing that ticking up now, and really everyone within the industry is expecting that the impacts are going to be quite significant for the long term here. The good news is that telehealth is increasingly becoming a go-to solution, and in many instances, a preferred solution, both for the clinicians and for the individuals that are involved with this. Home-based services are increasingly becoming the expectation in a lot of situations. And so while certain hospitals and clinics are seeing some slowdown in the delivery of services from some of their common users, we're starting to see another group of patients that are trying to access mental health services, and they're really turning to telehealth as the solution for receiving those services. All this leads us to believe, as the next slide tells us, that we're at a tipping point for telehealth. There's a lot of dynamics happening right here. We're going to get into a number of these, but I want to quickly summarize some of what's happening out there. So right now, there has never been better reimbursement than what exists right now for telehealth. That's true really at the CMS level with Medicare, and we're seeing state Medicaid programs and commercial insurers paying for telehealth on par with in-person services and showing a lot of flexibility in the types of professionals, the types of services, and the modalities that are being reimbursed right now. We're also seeing a lot of the regulatory barriers that have impeded the growth and the adoption of telehealth are coming down right now. Naveen is going to get into that in more detail. And we're seeing like remarkable levels of adoption, both with the patients and with the clinicians, and turning toward telehealth solutions. Many of you are probably newer to using video conferencing. And sometimes I think we find that there might be a high barrier to getting people to try interacting with this way the first time. But once folks do, it's hard to get them to go back. And so we're seeing that adoption curve is increasing right now, and we're expecting utilization to stay quite high. So you layer all of those kind of favorable tailwinds behind telehealth, and you layer in all of the stressors of COVID, and we're seeing rapidly increasing demand for telemental health services, and it's causing all of us to think differently about how we need to deliver those services and the modalities there. On the next slide, I can touch on a couple of common applications for telepsychiatry. So one that most people are probably familiar with is over on the left-hand side of the slide. That's what the industry typically calls a scheduled service model of telepsychiatry. The typical use case there is an individual presents in a clinic where they will see their psychiatrist or their behavioral health clinician via video. That clinician is working likely from home and beaming into that clinic to manage a caseload of patients on an ongoing basis. Very typical model of telepsychiatry. On the right-hand side is another model of telepsychiatry that's been around for a little while. That's what we call the on-demand service delivery model. Typically, that's used for acute cases of psychiatric crisis, often targeting hospital emergency rooms and psychiatric screening centers, where the necessary service is a timely evaluation of that individual by a behavioral health professional in the moment to figure out what's the most appropriate, least restrictive level of care for this individual right now, and how can we help get them on that track. One of the newer versions of telepsychiatry and telebehavioral health that are out there is really represented in the middle of the page with this idea of delivering services at home. There have been a number of telebehavioral health platforms out there for a couple of years now that operate a lot like a virtualized outpatient clinic using a telehealth platform to deliver those services. And that's been growing in adoption for the last couple of years, seeing massive increases in that delivery mechanism right now. And one of the really interesting things is that we're seeing this blending between all of these models, right? So scheduled service models where an individual used to receive their telepsychiatry within a clinic, those clinics are now having to adapt to manage and deliver those services directly to the individuals in their homes. And so there's a bit of a blending happening right now that we think is likely here to stay. On the next slide, I can highlight how some of this is really playing out between a facility-based model and a home-based model. So Increasingly, facilities are facing closures. They're facing challenges getting their own workforce on site, and a general sense of anxiety and precaution is causing many of these clinic partners to scramble and convert to deliver services directly to individuals in their homes. A really simplistic overview of this might think, hey, that's pretty easy. We'll just activate video conferencing and you can see anybody in their homes, right? Video conferencing is getting to be ubiquitous. Well, that doesn't always work in a clinic-based or a clinic-run telepsychiatry model, right? Typically, what these folks are used to is opening up a video conferencing session at the beginning of a block of time and having individual consumers come in and out for their sessions, right? The delineation between sessions is when that person physically enters or leaves the room. Well, when you're doing that at home, it really doesn't work because you need to be able to create distinct video sessions between the patients. Fortunately, that's possible with most video conferencing tools, but you got to make sure that the right patient has the right link to the right meeting at the right time. And that can be a real scheduling nightmare. You got to be able to email out all of those links. And so some of the technology tools that we're relying on to deliver telepsychiatry to individuals in their home have some unique challenges. There are a lot of tools that are out there right now that bundle the scheduling and the video conferencing together, but they often also include features that may or may not be applicable, like clinical documentation, e-prescribing, and ultimately billing and practice management software. Many of these clinics don't need all of that enhanced functionality because they want to keep that functionality in their EMR. And so the short answer is that converting a facility-based model to a telehealth model has its unique set of complexities. The good news is everybody's really being creative right now, scrambling around, putting solutions out there. That's excellent. We've seen a preservation and a continuity of care beyond what I think any of us would have expected. But a lot of these things are relying on workaround solutions right now. There's a lot of kind of Scotch tape being put on the delivery of services right now. And I think we as an industry and as a group of providers need to challenge ourselves to how are we going to make this delivery model scalable and sustainable at a high level of quality into the future. And it's been exciting to see people start to think and focus on that right now. So really quickly on the next slide, what we really wanted to highlight here is this idea that behavioral health exists on a continuum of care. We all know that a person's mental health is not something that any of us are going to cure, something that we're going to manage throughout a lifetime, and something that's going to play out over different levels across that continuum, right? That acute emergent evaluation in a hospital, inpatient units, outpatient programs, and ultimately individuals' homes. The really cool thing is that telebehavioral health is helping us connect those different points of the continuum together, and we can offer enhanced consistency in care. And I think that's something that we as an industry should all be really excited about because it's ultimately going to deliver better outcomes to the folks that we serve. So hopefully that wets your whistle on some of the applications of telepsychiatry that are out there right now. And I'll turn the floor over to my colleague Naveen to talk a little bit more about our regulatory environment.
Great, thanks Jeffrey. So as I mentioned, I've been an attorney since 2006, and really a lot going on right now. And over the next couple of slides, I don't mean to oversimplify the various rules and regulations that affect the delivery of healthcare services via telemedicine, but just wanted to sort of bucket it in a few different buckets. And of course, we want to leave a lot of time for questions because there are a lot of questions, and the rules and regulations have just evolved even over the past couple of months. Even over the past couple of weeks. So there's a lot that's been updated. But the way I think about it is really there's a few main buckets and in the integration of our services with our partners. One is provider licensure and how can a provider deliver services across state lines if they're not licensed in that state. Two is the prescribing of controlled substances. The prescribing of medications, there's a federal rule that governs this. I'll get into that. Three is privacy. And so Hipaa, what can you use to deliver these services? And then on the next slide, I'll get into reimbursement amongst the different payers, so Medicare and then state Medicaid and commercial. Sorry, we can flip back for a second. So getting further into licensure, almost every state, I believe every state but Arkansas has passed some sort of loosening of a restriction on provider licensure. And it's really in three different manners. Some states have a blanket sort of any provider who's licensed in one state in the United States can deliver services into that state without having additional licensure in that state. Now that will only apply during this state of national emergency. So the moment that gets lifted, that will no longer be applicable. So for an organization like us, for example, if these restrictions are alleviated, if they're loosened, what we're doing is we may be taking advantage of the temporary restriction being loosened, but we'll be applying for permanent licensure at the same time. Most of these states don't allow for expedited permanent licensure. So that's one bucket where the state says, if you have a license in one state, you can practice in our state. Another bucket is applying for expedited licensure. So some of these are being turned around in 24 hours, but you can apply if you have license in one state to receive licensure in another state, and it's expedited. It takes a lot less time than it would have before. Three is there's states that have one of the above, but they may have restrictions. So for example, California and Texas have restrictions as to where the services can be delivered, i.e. only in a healthcare facility. And in some cases, that facility has to apply on behalf of the provider for the licensure. And so it's really nuanced, and you have to study these rules in each state to be able to understand how this will be applicable. But the good news is this allows us to do a lot of what we've wanted to do over the past decade, which is increase capacity. As Irene mentioned before, there's a shortage of behavioral health providers across the country. And so if you alleviate this burden on licensure, you have more of an ability to deliver services in areas that traditionally weren't receiving the care. Second, I'll get into prescribing. So the Ryan-Haight Act is a federal rule that governs the prescribing of controlled substances via telemedicine. Traditionally, without an in-person visit, it's been difficult to prescribe medications via telemedicine unless you are qualified for a number of exceptions. The main one that facilities have utilized is that the patient is going into a clinical care site. Now, with these, the Ryan-Haight Act has now been loosened, the DEA has loosened the restrictions, so now a clinician can prescribe controlled substances even if a patient is sitting in their home. However, this will only apply for the emergency period, but it is a significant deviation from what was in place before. And so now this gives us more of an ability to deliver services into the home. The third bucket on this page that I'll talk about is Hipaa. And really what the law states is that you can use platforms that are not necessarily fully Hipaa compliant, but you have to use your discretion, so they can't be public facing. So I think I saw something about Facebook stories and or Facebook Live, whatever it's called, and Snapchat. And like, I mean, I would have thought you would know this, but I guess the point is use common sense that you would use something like FaceTime or Skype, and that would be fine. But if you're using something that's publicly accessible, then it would not qualify under these new exceptions to Hipaa compliance. We can move to the next slide. So the third big bucket that Jeffrey touched on earlier is never has there been a better time to deliver services via telehealth because reimbursement rules have been significantly alleviated. The biggest one is probably Medicare. Medicare traditionally had a restriction on the clinical care site. Not only did it need to be delivered at an originating site, which was actually a clinical health center, but also it was only restricted to rural areas, so non-metropolitan statistical areas. That made it particularly onerous for anyone that wanted to bill Medicare to deliver telehealth services. That burden's been restricted. Now a patient can be sitting in their home, or a site can be outside of a rural area, and now they can be eligible for Medicare reimbursement, and at significantly the same rates as would be delivered, would be for sites, services delivered into a clinical care site. The other two are more I guess, state by state. So we have these Medicare CMS rules that are out there. I'm not an expert on billing or reimbursement by any means. So at a broad level, though, I believe like 48 states have followed suit with CMS and passed some sort of rule that allows for reimbursement for services delivered into the home, which traditionally wasn't the case. So Illinois has been pretty vocal about that in terms of being able to be reimbursed by Medicaid for services delivered into the home. And then commercial payers are really loosening up restrictions. I think Blue Cross Blue Shield has been at the forefront of this, waiving copays and deductibles to incent folks, providers, to be delivering services via telemedicine. That's a quick overview, but I know we wanted to leave a lot of time for questions, so I'll turn it back over to you, Jennifer.
Great. This is excellent. We've got a lot of questions coming in right now. I know there are a couple questions up here, though I think would be good to just jump into a few of these up here while we're organizing the other ones on the back end here. But you know, there are a lot of programs that are kind of getting up to scale very quickly. I'm wondering if, Jeffrey, maybe you can talk about how are people scaling so quickly? So how do people do this if they want to, this sounds really interesting to them, they want to get in on it. So can you give us an example of how you kind of brought somebody up to scale quickly?
Yeah, I think one, excellent question, and two, I think it comes down to getting kind of buy-in from the right stakeholders on what you're trying to do and the value that it brings, right? You might have clinicians who are uncomfortable with the idea of interacting with patients via video. We find that that's pretty easily overcome by just getting them introduced to the technology, doing some test sessions, you know, putting them in a situation where maybe their audio is out and you quickly kind of troubleshoot and find a solution. A second thing we'd recommend is having a simple backup plan. Right? Because of a lot of the flexibility that is out there in reimbursement right now, not every session has to occur via video, and we would strongly recommend that folks look at how can I just have a simple phone backup if I'm having some connectivity challenges. And I think the third thing would be trying to make sure that you've got a good link into your electronic medical record and the systems that you're accustomed to using regularly. Right, this doesn't have to operate entirely differently. You don't have to break many of the kind of back office functionality that you need to rely on. What you really need to focus on is how do I make sure that my remote clinician has proper access into that system where the encounter can feel as much as possible like we're occurring in person or within that facility.
So Jeffrey, can you switch back and forth between telehealth and in person, and how does that work?
You can, yeah, and so I think that's something that a number of our partners are experiencing right now. So they're developed a little bit of what we call a hybrid model, where some services are happening inside the facility, other services are happening in the homes. We're finding that different people are making those distinctions based on various criteria. Sometimes people are expressing a preference for the first session to occur in person, and then for follow-up visits to occur from home. Sometimes they're making a distinction based on the severity of illness, right? Certain types of diagnoses or encounters might be better occur in the clinic while others might occur from home. And sometimes it's limited really by the tech savviness of the clinician or the patient. So I think there's a lot of sort of decision-making criteria to figure out which services would we want to offer in the home or in the clinics. But there's just tremendous flexibility right now. Our experience has been that there's almost no clinical encounter that you cannot do appropriately via telehealth in this space. Sometimes it requires some extra facilitation, some extra thought, but we believe that our experience in the research has really validated that telepsychiatry, telebehavioral health is efficacious. Great,
thank you. And Dr. Epstein, Irene, as a practitioner, do you think that, you know, delivering the care in this way, does it alleviate some of the stigma maybe associated with services sometimes, or what do you notice maybe differently about some of your patients or you know, delivering care this way?
Yeah, I think particularly for in-home telehealth, that really can alleviate some of the stigma, maybe in part because patients do not have to show up to a facility to get care. They can do so in the privacy of their own home. So I found that that is one major factor that can alleviate some of the stigma. Also, just having access to care and knowing that it's an option in and of itself can alleviate some stigma, because it just kind of signals to everyone like, yes, mental health disorders are quite prevalent and we have a treatment for it. So just knowing that there's someone there, especially when it's integrated in sort of primary care, and a primary care doctor who knows the patient very well can refer them to see, say, myself or a colleague, that can also really help alleviate sort of the stigma as well. I've also had many patients who I saw through telehealth who have referred family members or friends to the services because they had a good experience and they felt like they were being treated appropriately and really getting the care that they need. So it's also just sort of word of mouth.
I mean, it seems like it would open up a lot of different types of therapy as well. I mean, is it possible to have kind of a virtual facilitator for group therapy, or are you seeing this with veterans or other types of therapy? I don't know if you do any of that in your own practice or have colleagues.
Sure. So we primarily in this company provide telecounseling, not so much group, but that's definitely something that is an option, something that could work really quite well with the technology. But we definitely believe that care is best delivered when it's integrated, and there are various levels of care, not just psychiatric in terms of diagnoses and medication management, but also therapy. So it's possible to deliver care both through it's possible to deliver care both psychiatric and counseling through this technology.
So Jeffrey, have you seen virtual group therapy or maybe virtual opioid recovery programs or addiction programs?
Yeah, so there certainly have been, over the course of the last year and a half or so, a number of substance use disorder programs that are embracing telehealth in various ways. As Naveen highlighted, some of that has historically been limited by some of the limitations from DEA on controlled substance prescribing via telehealth, but I think there is increased flexibility right now. We have gotten a lot of incoming interest recently to help employers, particularly employers in the healthcare space, by facilitating virtual groups. We've put together some pilot programs with that where there's kind of two different types of groups that we're running. So one is more of a peer support, almost psychoeducational group, where it can be a larger group that's coming together with a licensed facilitator focused on a particular topic. Those can be a little bit less formal, a bit of a drop-in type scenario where you can use video conferencing and somebody can moderate a group, not dissimilar to this. We also are seeing more actual group therapy programs getting designed. We've been piloting some for healthcare professionals who want to support their employee base, where it's a series of 4 or 6 sessions with probably a smaller group, 6 to 10 individuals that really commit to that group on an ongoing basis. And that is more of a therapeutic process group. So absolutely applicable and possible through this technology.
That's really fascinating. So Naveen, you opened up the can of worms about interstate practicing and all of this. So you've got a whole bunch of questions here. And I am curious what's going on in Arkansas. So you said they're the only state that isn't allowing it.
Last I checked, it's constantly evolving. So that wasn't to knock Arkansas. That's just last I checked. That was the only state that I hadn't seen with some rules out there. But it literally changes day to day. One thing I want to mention just before we get into this, Jennifer, is you talked about decreased stigma potentially, or Irene talks about it with telehealth. And one of the things we see, I work with a lot of tribal communities, Native American communities. These are rural areas. There isn't an ability to recruit that many clinicians that would practice within the area. And so there's a stigma associated with having someone in the community treating them. We have the ability to draw from a larger network. So actually we find that there's a better rapport established when these tribal members have the ability to engage with someone that they don't know within the community, there is sometimes a feeling of shame or with something where someone might tell someone within the community because it's so close-knit. And so another aspect of decreased stigma is if you implement telebehavioral health, sometimes it is nice not to know the person and be able to confide in them without feeling like they're going to communicate that within, amongst other members.
Yeah, it's a great point. Great point. It really is expanding access for a whole, all different groups of people. I think that's great. So you mentioned a little bit about prescribing and DEA regs and that providers can prescribe now controlled substances to patients. So if they've never met face-to-face, they are able to do that now, correct?
Correct. I think I should caveat that because I actually saw a question come in around CMS. All of these are temporary during the state of national emergency. And one thing to consider when implementing any sort of telebehavioral program is what do you have the ability to do in the short term, and then how can you make it sustainable in the long term? So we have a lot of experience with doing that. So currently, there is not the requirement for an in-person visit. You can engage and prescribe as a provider with a telebehavioral health visit. Now, because the rules state it and it can get reimbursed, there's standard of care. And so what I want to differentiate between is for an initial evaluation, for example, for a psychiatrist, most of the time, and Irene can speak probably better to this, they're going to want to see this patient over video. They're not going to want to do this via phone. Even if the rule says that we can do this by phone, even if the reimbursement states that it can be reimbursed, we also want to consider what's appropriate from a medical board standpoint, from a comfort standpoint. And so a lot of this there's a number of different aspects and layers. So you really need to understand all the different implications. It's not just that the law says this so we can do it, but when you think through the implementation, there's a number of other aspects, including what the clinicians are comfortable with. So I think we're at the forefront of that because we're working with a number of clinicians like Irene to figure that out.
So you're getting this question that we've gotten on every single webinar we've done, is with all of these changes, and I'm just going to ask you to make your prediction, do you think after this state of emergency or goodness knows when this is going to end, but after it ends, do you think they're going to roll these back, or what's your best guess in terms of where we're going to end up, let's say a year from now?
So I'm going to quote Jeffrey. We were on a call a couple days ago, but it's actually Seema Verma, who's the administrator for CMS, stated that the genie's out of the bottle and there's no way it's going back in. Now, I'm not going to say exactly what that'll mean, but clearly now that people are seeing the benefits of telehealth, in some capacity restrictions will be loosened. What that is, we don't know, but I think we all know that it won't be rolled back completely. And so there is going to be the ability to deliver telehealth on a more broad spectrum without these restrictions, or some of these restrictions. Jeffrey, I don't know if you might have more to say to that because we just talked about that.
I agree. And I mean, at this point, it's the $1 million question that I think we're all interested in. And obviously we're just sitting here speculating, but I guess we're speculating from some sense of experience within the industry. I completely agree. I think the genie is out of the bottle. I think people have come to expect that telehealth is going to be a regular part of how they receive care. And if the regulators try to wind back to where this was before, there's going to be a lot of upset providers and consumers of healthcare services. If I had to guess, I think we're going to see permanent changes around reimbursement for telehealth services, right? I think many of the Medicaid programs are going to continue to reimburse for telehealth beyond the state of emergency. I think CMS is going to have to get more generous with reimbursing for telehealth services, but I don't think we can expect that all of the flexibility that's out there right now is going to stay, right? Like, I'm not sure that phone consults will always be fully reimbursable as though an in-person session happened. I think that, the DEA, we've been struggling with the DEA around telehealth prescribing for years. What exists right now is not a definitive action that was taken by DEA to create exceptions for telemedicine prescribing. What basically happened was a standing exception that was already written into the Ryan-Haight Act in the event of national emergency. So as Naveen said, as soon as that national emergency goes away, you're no longer allowed to prescribe controlled substances without a prior in-person encounter or without one of 6 other exceptions being met. So I think that's going to snap back relatively quickly. I think flexibility and licensure probably is going to come back toward the norm relatively quickly, but I think states are increasingly going to embrace things like the Interstate Medical Licensure Compact and some other options for license reciprocity. So I don't think that they're going to give up the sovereignty of their licensure process itself, but they'll probably get more creative about how they would work with other states and what flexibility they want to offer practitioners.
Yeah, I mean, that really seems like a benefit in terms of expanding access. You've got, people who don't necessarily have access to some of these providers in states with limited practitioners. So, I mean, yeah, it'll be interesting to see where this goes. All right, well, we'll see which of you is right a year from now. Hopefully the genie stays out of the bottle. Dr. Epstein, Irene, these are all wonderful ways to deliver care. Are there any types of mental health that you think are just not amenable to telehealth care or telemental health? Like, what are some of those examples where you just don't feel comfortable with it?
Sure. I think that, well, first of all, the data backs up that telehealth is appropriate across populations, across diagnoses, and it really works well for the vast majority of the patients that I see. There might be the occasional patient who just has the preference to see a clinician in person, and I think that is valid, and it's something that we do have to respect if that is the preference and that is available. There are some patients who, because of their mental illness, might have some kind of concerns or paranoia around video conferencing. So that occasionally comes up, but it's interesting because I also have some patients who are very distrustful and have paranoia as part of their mental illness that prefer video conferencing sessions because there is a bit more of that distance there, so they feel a bit safer. This is also true for patients who have high levels of anxiety or have traumatic backgrounds and also feel uncomfortable with that sort of real intimate experience with a clinician that's in the room. Additionally, I feel that there are some patients who have a lot of cognitive limitations who might not do as well with the sort of the back and forth that we kind of rely on with video conferencing, and especially with phone, where we're really kind of relying on patients to be forthcoming and kind of really tell us what's going on. And even with some patients who are really quite ill, video conferencing and just telehealth in general can work really well, but there might just be the requirement for more support from, say, the clinic or just other sort of levels of support to ensure that the patient is doing well. So many of our patients have many medical comorbidities, and being able to sort of coordinate with primary care doctors, therapists, caseworkers is also really important. So there are many patients who video conferencing, it works really well and we can treat them well, but we do need additional support from other mental health clinicians and also medical personnel.
And so it sounds like you are able to do, though, a lot of these initial visits with patients over telehealth. Can you talk a little bit about, some of the best practices around what's an initial visit look like using telehealth?
Sure. And are you referring to video conferencing, right?
Yes.
Okay. Just because, so in my clinic, we have switched over to in-home care for most of our patients, but the intakes, the patients who I'm seeing for the first time, are coming in to the clinic so that we can do video conferencing, since we don't have that capability just yet in their homes. And I will say that the initial visit is almost identical to what it would be if I was seeing a patient in person. So the way that it works is, we have the video, the room is set up for video conferencing. I am at home, I'm seeing the patient, and they are brought into a room that is dedicated to the video conferencing session. A nurse will bring them in, do vitals beforehand, give me a little bit of information. I'll have access to their chart. I have remote access to their electronic health records, so I already have a good amount of information about that patient, which is equivalent to what I would expect when it would be sort of, I would be seeing a patient in the clinic in person. So I'll have some evaluation, some of their previous records, other information that is sort of pertinent, and we will conduct the session. I have the ability to see the patient, their whole body, so that is not different. It's not like I only see their profile like what we, our situation right here. We will conduct the session, and at the very end, I will work with the staff that's on site to help coordinate next steps. So if that's scheduling another appointment, getting some laboratory work done, referring to primary, or establishing care with a therapist. So really kind of equivalent to an in-person session. And of course, in the beginning of the session, I always educate a patient about it and kind of gauge their comfort level and encourage them to let me know if it feels uncomfortable for them or if this is really just not the modality for them. And I think patients usually really appreciate it. And I've really kind of had patients towards the end of the session say, I don't know, this isn't working for me. So it's really worked quite well.
That's great. That's an important point. I'm glad you mentioned that. So Naveen, of course, the infamous 42 CFR Part 2. And for those on the line who don't know what 42 CFR Part 2 is, perhaps you could explain what that is. But what are the changes made in that in the wake of COVID-19? Could you talk about that a little bit?
Yeah, could you just direct me to which part of it you really wanted me to focus on so I can be a little bit more prescriptive? I don't know who the person who asked the question wants to know, but what changes were made or how is 42 CFR Part 2 changing in the wake of COVID-19? So I would say, are there relaxations in terms of what information can be shared perhaps, or privacy information? Yeah, so
that would be
in
my
terms
guess.
of sharing of information, you know, the privacy rules, I talked about the platform aspect of things, but in terms of sharing of information, you know, I think we're generally still following the same rules. I think the problem is we don't want to tackle something short term and then not have the ability to have this be sustainable. So at least from my perspective, so I only speak from my perspective because when we're delivering a solution, we're thinking about long-term implications. So a lot of times we're leveraging the rules that are in place now that are short-term, but thinking with a mindset, because a lot of our partners are working for multiple years, you know, how is this sustainable? So in terms of privacy, I mean, we're typically charting within an electronic health record. We're not sharing information via email or non-secure methods, and we want an ability to be able to reference that record. A lot of what we're doing is still integrating within primary care clinics, for example, and there may be, you know, a desire to see that note. Also, our clinicians want to be able to access a health record to be able to see things like Irene's going to want to be able to see the medication history of someone when she's evaluating in a patient to determine there's no contraindications. So from our perspective, and I only speak from our perspective because, you know, I'm not practicing as a lawyer full time. I'm really looking at the laws that are in place to see how it affects our business. We're not really changing a lot of what we're doing. All we're doing is tweaking things. And in some cases, we're adapting to the environment. So if we're working in a clinic and there's not an ability to have patients coming into the clinic, then we're delivering services into the home, but overlaying a lot of the same methodology that we have with the clinic. So again, charting with an electronic health record and things like that. So I don't really have a perspective as to how you could take advantage of it because, again, it's temporary. And a lot of this, we want to think about what can we do in the long term. So if you're using, a lot of the clinics, I'll give you an example, a lot of clinics we work with are thinking about a telebehavioral health platform and whether it's HIPAA compliant. Now, although the regulations say you can use FaceTime and Skype, the thought that they have is, well, I don't want to make an evaluation 3 months or 4 months down the road or however long it is, or a month. and then be in a position of having to switch it over. I'd rather set this up now so that I can continue to deliver the care and I'm not scrambling. So I think that's how we're really thinking about it. Yes, these regulations are in place and we can take advantage of them in the short term, but how can we make sure that in whatever environment we're in long term, whatever's peeled back, we still have an ability to continue to deliver the services? Because we're really focused a lot on continuity of care, particularly in outpatient and at-home settings.
I think some of the concern is, you know, Hipaa doesn't always, you can make exceptions during a public health emergency. So there's concerns among, you know, some patients that perhaps their privacy won't be as protected during this public health emergency because, you know, there's kind of this easement, and that's so that information can flow more quickly. But I do see that one of the participants from today has sent out a link through the chat to SAMHSA's guidance on Part 2, just if anybody's interested in that, if you really want to get down in the weeds. Thank you for sending that out. We're delighted to see. We've always got everybody on the line that we need to have on the line here, so that's great. Naveen, are there any other kind of risk management or liability issues that you think are specific to, you know, telemental healthcare?
Yeah, I think particularly when you're thinking about delivering the services into the home, but anytime you're delivering a telehealth solution, I think if you think about informed consent, you need to make sure that someone's comfortable receiving the service this way, make sure that they understand that this is an option for them. And then on a state-by-state basis, some states have requirements that you get a written informed consent. Others say verbal is fine. And so it varies by state in terms of getting that consent. But then in terms of risk, if someone's receiving services in the home and they have suicidal ideation and they've been in an emergency department more recently, we're going to want to screen for that. Any provider is going to want to screen for that and understand and make sure they have resources available if there's a crisis. And so when we're in a clinic, it may be different because someone is outside the room and can make sure they call the appropriate resources. If it's in the home, we want to make sure we're screening for the type of service. And I know Jeffrey can speak more to that as well in terms of empathy in our at-home service and how we're doing that, because we have a care navigation team that's really calling and making sure it's the appropriate patient for this type of service. So absolutely there's increased risk, and you need to make sure you have a system in place to be able to identify that and ensure that you are delivering services to those who are clinically appropriate.
I'd like to just add that we are moving a lot of patients from the clinic setting to in-home, and emergencies do arise. And if, like Naveen said, we have to have an emergency protocol in place in case it does. So we've been working with individual clinics to kind of help them achieve new workflows, including new emergency protocols. So it's actually important at the beginning of a session to, of course, obtain verbal consent for the session, tell them the reasons that we're doing this via in-home video or audio, but we also want to make sure that we get identifying information and also confirm their address. So in case of an emergency, we can call the local authorities or get assistance from our facilitators at our respective clinics to help activate the local authorities in case of a crisis situation like that.
Okay, Jeffrey, we're coming to the end of our hour, so I want to get the last question to you. One of the statistics on your slide said that 80% of people believe those that need services will not get it. So what are some, I guess, best practices, or how do we address that perception right now?
Yeah, it's an interesting point. I mean, the reality is that the supply and demand for behavioral health service, those lines are really imbalanced, right? There is increasing demand for behavioral health services and unfortunately decreasing supply in a lot of instances. And so the sort of telepsychiatry that we're talking about right here doesn't entirely solve that. What it allows us to do is distribute those scarce psychiatric resources better, but it doesn't necessarily create more psychiatrists, and it doesn't necessarily make our psychiatrists or our behavioral health clinicians more efficient. I think that's going to be a really exciting thing in the evolution of the industry, is as extra technologies like online CBT and artificial intelligence and chat and other telehealth advancements start getting integrated in the typical clinical workflow, it's going to allow us to use the practitioners that do exist more efficiently to reach more of the people that need those services.
Well, that's a great note to end on. And I just want to thank our panelists today, Irene Epstein, Jeffrey Boyce, and Naveen Kathuria. This has been really an incredible session, and we've got so many questions we were not able to get to today, but thank you, and thank you to Insight and Regroup for sharing their knowledge with us today. We could do this for another 3 hours and still not get to everything. Such an important topic. So thank you, everyone, for joining us today, and we will send out tomorrow a link to the recording and materials and contact information. If you want to get in touch with Jeffrey or anybody else on the team here, I'm sure they'd love to talk to you more if you've got additional questions. So thanks, everybody, for joining us.
Thank you all so much.
Thanks very much.
Bye, guys.
Bye.
Have a wonderful day. Stay safe.
Bye-bye.